Great, thanks. Next, I'd like to introduce Sean Tsuda. He's the associate professor at the University of Nevada and director of simulation as well as bariatric and robotic surgery out of Las Vegas. Your presentation. Okay. Yeah, no problem. No problem.
Come on
so
up.
yeah, so come on up. Actually, I'll give you a seat. Have a seat. Yeah, so we'll take the advantage. So Sean Tsuda, and then of course Dan Jones, sitting president of SAGES. He's been a real force in simulation and works out of Boston, a professor at Harvard Medical School and chief of surgery at Beth Israel Deaconess Medical Center. Very involved. We're fortunate to have him join us here. So we've had a couple presentations. We have a couple civilian counterparts. The idea here is to talk about surgical simulation for readiness. And I can open up the microphone to questions, if you have questions.
Yeah, thank you very much. Great talks, guys. Thanks for your presentations. And I'll take the hit for Dr. Tsuda and Dr. Jones. They did ask me a couple of times, and I swear I thought it was a panel session, so I apologize. But the reason why they're here is because they are both actually recognized experts in simulation for surgical training, which leads me to my question. So the problems we have in the military are, one, graduating cases and making a certain a level when you're graduated from residency, and then when you go deploy and don't do that skill, and you heard General Place talk about losing your ability when you're not doing any cases, it's magnified when you come home and you're trying to establish yourself as a surgeon, gain some confidence, hopefully do some more complex cases. What role do you see simulation in the initial education, and what role do you see if there is a role on the other end of your deployment that simulation can play? Does it help? Do some of the things that Dr. Brand talked about have to be incorporated? What do you think? And I'm not talking about combat skills now. I'm just talking about regular old garrison skills. Thank you.
Yeah. First of all, thanks for inviting me to be here, Gordon. And Rob, I'm a civilian, but I'm very respectful of all of you in the military. Thank you for your service. I have family members who are combat veterans of the military, so very, very, very honored to be here. What you mentioned is kind of close to home for me in Las Vegas at our civilian academic hospital. We actually work closely with our military counterparts on Nellis Air Force Base, and they've approached me in the last few years about this very issue with re-entry and skills, particularly related to laparoscopic surgery. And now we have people interested in robotic surgery and jumping on that wagon. So we've implemented and using a combination of an apprenticeship model clinically and the simulation and skills lab. We sort of used FLS as our baseline. So, you know, as far as the rigor of the predictive validity in terms of training things, FLS has that rigor. So even if someone was FLS certified, say they did it 2 or 3 or 4 or 5 years earlier, we had them redo it to a level of proficiency. And then sort of created our own laparoscopic / robotic curriculum for them, combined with clinical shadowing or mentorship. I think the last person we did this with was Brandon Snook, and we've even done cadaver and live animal-based laparoscopic labs, I think with Sean Neeson. I'm dropping names because I feel like you guys all know each other. So that's sort of what we've begun to implement, but the interest is still there. What I would say is, as from what I can observe with the military, you have a big advantage. And one thing about you all is you realize there's a need and you just implement stuff. If you try to go with what we do in the civilian world and our adherence to evidence-based medicine, it can take 10 or 20 years to validate something and get it out there. And you know, if you just type surgical simulation to PubMed, there's 20,000 papers and almost none of it reaches that level of clinical predictive validity. Or if they do, there's severe methodological problems with it, or they're underpowered. So sometimes we just have to implement at the same time as we work on the research and those things. So what I would encourage is military people are interested in brushing up on their skills to work with their simulation champions, local simulation champions, use the data that's that's available to us now, and just create something and implement it. I do like the CSATs idea, which is the evolution of the OSATs, which is crowdsourcing. Within you have a unique network of people who can use that idea to sort of validate videos of either simulated tasks or real tasks in the OR. I mean, I would really encourage you guys thinking about creating your own. CSATs, I was talking to Rick Sotava earlier, I think was just bought by Johnson & Johnson. So that's going to be a highly commercialized product, and not something that might be easily accessed without a lot of money. So kind of creating your own thing with the same concept might be the way to go. Sorry about the long answer. Dan.
So the first thing you have to do is tell any bias you have, and my bias is for the Army. That's who I'm rooting for in the football games. Sorry about that. But my dad was a career Army officer. My son's at Fort Lee, Virginia right now in the Army Reserve. So go Army when it comes to football. Recently, that's paid off. In terms of readiness for training, I think that you guys get deployed, and because you're not doing things for a while, you're probably more concerned about your skills than is really there. I've had the privilege of taking 5 soldiers into our Navy and Army into our residency programs, and they've been deployed and many times and been out maybe 5 years, and they have a little bit of insecurity in doing some of these general bread and butter general surgery cases, but outside of hernia. But they're all very skilled, and it just takes a very short window to get you comfortable and back into the seat of the things that you need to do. If you have the skills, learning the advanced operations that you aren't doing all the time, I think comes naturally and easily. I'm much more worried about, in this case of a disaster, the surgeons in the academic towers dealing with these catastrophes. We had a bomb go off in Boston, and my ex-fellows were all texting quickly, telling us how to put on a tourniquet and how not to put on a tourniquet, because they knew we had no idea, and we were going to start causing some harm. So I think, a real important area for the military to think about in simulation is really training the general surgeons who may be just doing gastric bypass or bands or sleeves or hernias or foregut, and how to take care of these disasters when they occur, because there's no doubt there's going to be more of them, and we can help out. We've been out of our trauma rotations for decades, but again, I think we have the basic skills, and if we could refine those, that would be good. So my take home is you guys are a lot better than you think you are. When it comes to simulation, you're great. I mean, there's a carrot and a stick, and because you always have a stick, we get 100% compliance when we start doing simulation at Uniform Services Medical School. Much better than Harvard or any other place we could go. And you guys adopt and you understand the concept of practicing outside the theater in order to do well in theater. And so that knowledge base gets you so far ahead of the average general surgeon and guy in practice who's trying to learn these skills. So I think my bottom line is you guys are doing great. You're doing a lot better than you think you are. If someone's out a couple years and wants to do a fellowship, we love to have you at Harvard. We got a great track record, and a few of you guys are here.
Real quick, Gordon, I just want to jump on that thing about disaster readiness for civilians. I think the civilians, we have a lot to learn from you too, with what you learn about combat readiness, preparedness. We recently had the shooting in Las Vegas, and our military colleagues there, Doug Frazier and Paul Chesterfish and so forth, were extremely helpful in taking care of that disaster. And it really outlined for us that those of us don't do trauma on a regular basis, maybe have the need to have that kind of skill brush up for severe low frequency events like that.
Great. If anyone else has any questions, I have a question. So what we've talked about today earlier is readiness is a big issue for us. What skills, what training are we doing? What cases are we doing at our main MTFs? And as we get subspecialized and technology advances, there's a divide between what we're doing at our main MTFs in the U.S. versus what we're expected to do overseas. And overseas, it's a lot of open surgery for sure. And then back at the U.S., it tends to be more MIS for the most part, and certainly robotics is very popular. So it's an overall question is, how do we prepare our military surgeons who are training at MTFs to then go overseas and do a very different environment? Now, I know Ahmad Haq just shared with us some of the training he's doing, and that's certainly that's very important. But what we try to argue at the main MTFs is if we're doing MIS cases, do we think that translates over to open cases? So if you're, say, doing a robotic case and then you're doing anastomosis, you're doing that anastomosis, it would be laparoscopic or open. Does that translate, or is there a need for some development of simulation, like open simulation would be a common thing, doing cadavers, open simulation to then complement what we're doing back at the main MTF. So it's a specific question has to do with robotics. If you're doing a lot of robotics, does that really translate? If you're training urologists and they're doing all this robotics, then all of a sudden they don't have the robot anymore. Can they do laparoscopic or can they do open? You kind of get in a bind. That's an overall JME issue. But what we try to argue is what we're doing in the main MTFs, does that translate, or do we think that we need a separate simulation to make up for the less open surgery that we're doing? So I know it's kind of several different questions built in there, but I'll let.
So again, what you're saying is it always looks greener on the other side, and if I'm getting this, am I missing something else? Clearly, if you can do good general surgery and you understand all the principles of that operation, that's going to help you do laparoscopy if you have the skills and you practice the skills however you got them, whether it's in a trainer or in real life. If you got laparoscopy down, that's useless unless you really understand the principles of the surgery that you're trying to accomplish. Simply being able to tie a laparoscopic knot by itself isn't going to get you very far. So you really need both. And in fact, if you look at the SAGE's Advanced GI MIS Fellowship as of what's coming out of this meeting, 10% of that counts is open surgery. In other words, there's now a recognition that if you want to be a good MIS surgeon, you got to have some open skills. And again, I think there's lots of ways to get those. Things I would encourage people to do from SAGE's point of view is do FLS. It gives you some basic laparoscopic skills. Do FES is going to give you some basic endoscopic skills. Do FUSE, just because I have the pin and I'm really up for it, and actually it's important. There's 600 fires a year and it's preventable, and you're going to have that in any environment. I think you got more skills than you give yourself credit for. And I think however you get the experience, if you think about it, it's going to help you do the other things you need to do. And even, once you have the skills, if you're working with another surgeon, scrub in, get that other experience, see how they're doing things, see how they do things differently. I mean, that's when you really start learning is not when I apply my laparoscopic anastomosis to my open cases. It's really when I see someone else do, old-fashioned open, anastomosis.
Yeah, I would agree with you, Gordy. There is a significant gap and need for curriculum development for simulation for open surgery. And its applicability doesn't stop at the austere war environment. It extends into converting local cases for intraoperative complications like vascular injury or otherwise. And I made that pitch to the American Urological Education Council last year that we do course development in that area specifically, and they weren't interested in it yet, but I could see as the need becomes greater moving forward, they could gain some more interest there. But I agree with you, it's a gap.
Well, I'd done dozens of laparoscopic gastric bypass before I ever did an open gastric bypass. And that wasn't the way it was supposed to happen, but when I had to open, I'd done enough laparoscopic cases, I knew what to do, it went well. Now, there's nuances to exposure and things like that with retractors that you could develop over time, but you can get that a lot of different ways. You can get that watching videos, you can get that reading books, you can look at it getting atlases, and yes, you can get it through simulation, but I don't think simulation is the one answer, it's just one of many ways to learn what you need to learn.
Agreed. I would envision it as part of a psychomotor and cognitive curriculum with that endpoint.
Remember, though, if you are going to use simulation, OSATs was originally developed with open procedures. So that precedence is there. It's a evaluation model, and we have things like cameras, so all you need is a decent open model or a cadaver or animal-based model, and you can simulate something like an open gallbladder or a bowel resection.
I have a question for Ahmad Haq. So certainly you have a big effort going on at the Army Medical Simulation Center here in Seattle, and you have certainly it applies to all services, and there's quite a need. What is the I guess the audience? Are you, in terms of your simulation center, are you pretty much, is it you're mainly training Army in the Northwest, or did you draw from the rest of the country in terms of teams being ready to deploy?
So Greg, thanks for the question. So locally, it's a local regional platform, so we train local regionally. ATLS courses are usually a quarter of them are Navy, and a smattering of Air Force, and representative of the number of basically the military population in the Northwest. So local regional, primarily for cost and convenience, more than anything else. It's trained a number of reserve FSTs that are desperately looking for ways to train, especially if they can't get into the formal trauma training centers, or if they have late notice deployment orders. This was more a few years ago when they all came through Fort Lewis, that we would offer them said training opportunities. So I think in the end, to ask about your audience, I think it's absolutely expandable in terms of surgical skill set. Because they are defined numbers with defined models, and I think one important point that I want to add to the open model idea is that there's an environmental piece to it as well. So if we can recreate that environment and recreate the stress and the relative austerity and problem solving in a simulated environment, it's safe. No, you're not getting shot at. Got it. But it can sound like it. The lights can go off. There can be unexpected visitors. There are other things that make those distractions that are very real, that for surgeons in the room that have deployed understand that is very real. And so how do you prepare for that? How do you prepare for that mentally, and how do you continue to do your open surgical skills while all those things are happening? So again, long answer to your question, but it's yes, open, I think, and applicable. Now, do I have a moving shipboard model? The answer is I don't. But I think there's certainly ways that those can be.
So now you've moved into the power of simulation. You've got away from the knot or the stapler, which honestly you should be able to do no matter what it is, and you've moved into simulation, which is where the power of all this is. Okay, can you tie the knot under pressure? Not can you not tie the knot? Can you communicate? What's the technical, non-technical activities going on there? Who's in charge? Where's the leadership? How are you going to deal with that? So it's the stuff that Lord Darcy talks about and Resnick talks about, and this whole team training thing applied to surgery, which you guys do all the time in other environments anyway. That's the power of the whole simulation. It's not to tie the knot and do the operation. It's how to be in a combat situation under stress, or when the lights go out, or there's excessive bleeding. How are you going to work as a team to solve that problem, not what your individual skills are that you may or may not be missing. We've looked in simulation at seasoned surgeons versus young MIS surgeons, and you know what? Those old guys, which I'm approaching, they use their assistants well, and whereas the young guy, he persists at kind of solving himself, and they're both going to get to the same endpoint of being relatively safe. But it's just a different way of doing it. And so I think that the power of simulation is in the group team activities as opposed to the basic skills. Sean, you've done a lot of this. What do you think?
Yeah, I think creating high fidelity with low fidelity technology, I think it's very possible to. You mentioned combat scenarios. We do the same thing, but with cold scenarios or silly scenarios, like not silly, but like the disruptive surgeon, or the nurse keeps walking out of the room. That's our civilian versions of your military
hostile fire
environment, right? And it is just as frustrating. So Exactly. I think that's an excellent way to implement a program, is doing a full team training fidelity, high fidelity model.
Romy Ignacio, San Diego. I appreciate your comments, Dr. Jones, because I believe, obviously, is that we have the skills, we have the training, but it's really the team training. The majority of the time, it's not just the surgeon, it's your team that makes the biggest difference if that patient's going to make it or not. So we learned from you guys over at Madigan what you guys were doing. I got some of my chief residents to go with the FSTs to do hyperrealism training, and they realized it wasn't about the skills, it was about how do I communicate to like 3 different teams that I got a whole bunch of casualties, how do I take care of that patient, how do I get a corpsman to take X, Y, and Z. You can't teach that in residency, and so I thought that was the most powerful thing that we learned from you guys, and we're trying to start that over at San Diego. The problem I can't get to the residents and stuff, because I'm a program director, is I tell them there's nothing here in the United States that's going to prepare you for an IED. You can go to trauma level 1 at Detroit, Chicago, whatever. There's just nothing that's going to prepare you for that. I try to tell them they're going to get the skills in residency, they get the team training, but if you are a program director, how do you tell your residents that I think we're doing a great job, we're never going to get to that part where I'm going to measure that you're going to be thoracic trained, vascular trained, or whatever. So how do I tell them that we're doing okay and that yet we're going to try to get to the next advanced step, or do you have a suggestion of another curriculum that can get them there?
So I think the challenge that you mentioned, I think as military training programs, we produce a very good product that are very sound, with good sound general surgery principles. In the end, it's the ability to apply those principles. So how can the curriculum complement that? Well, what are the uncertainties that make applying those principles hard? So we're used to applying those principles in an operating room where we're fully staffed and what we want when the circulator's in the room. It's readily available. But now you don't have those. What happens when those items aren't available? Do you really know when you don't plug the suction into the wall but into a device that it's at 40 decibels and you can't talk to each other when the suction device is on? Those are all the friction points that can you learn to function in that. So I think the goal of call it curricular if you will, but recreating the environment such that well-trained surgical residents who understand their principles, their surgical principles, can do it, but understand the friction points, understand the environment, understand the equipment, understand limitations, and understand the teams that they're working with, and having that understanding is really the power of the experience. It's an experiential model. Can I take a resident and say you are absolutely prepared to do an IED or be prepared? I really can't. I can't expose them to that. But again, the power of simulation is getting as close to that as possible. And I think that's really been the model. The other piece of the model is this: that we have the hospital model, and again, what Dr. Ploy is saying is like we're a garrison-oriented, medical commands, if you will, with this go to war mission. But how do we bring those together and train together, and not just when we're getting ready to deploy, right? Not when you get a piece of paper so you're going. How do we stay ready, and then specifically how do we train the next generation of residents to be ready when they walk out the door? And I think that marriage. And it sounds like you guys are kind of doing the same thing, that marriage early on of, in the Army terminology, it's MedCom and ForceCom. It's the units that go out the door versus the units that are home. How do we marry those so there's this cooperation between the two, and maximizing the funding resources, maximizing the opportunities, maximizing the environment? I think that's where we stand to gain the most. I'm going to take a quick second while I have the microphone. Is for the next couple of days, tomorrow, Thursday, Friday, from 10 to 4. One of the other pieces of is an opportunity to do simulation and experiences. So especially for the residents that are here, if you haven't seen a surgical team except in journal things, or maybe catch a National Geographic piece, on what it's like at a Roll 2. We're going to have a Roll 2 downstairs in the exhibit hall. For you to be able to see what it's like to be able to do damage control surgery in a Roll 2. In addition to that, you have a chance to actually do the triage and decide which patient you're going to take to that 1 OR bed in the Roll 2. When you have 5 bleeding patients sitting outside your simulated Roll 2. So the intent behind this, and this opportunity is here, for tomorrow and day after, and certainly your willingness to participate, and then obviously help us along with the process as well. We'll have complementary REBOA training along with that. There's stop the bleed skills, and then opportunity to do this mass cal triage exercise. So all of that is there, again, for maximum resident benefit, but as much as anything else for everyone else in the crowd as well.
Gentleman Wu Do from Madigan Army Medical Center, third year. So at the risk of being a little provocative, because we don't often have 4 people leaders in simulation, in a single panel, I'd like to push you a little further on the last question that our colleague had. So how far away are we from saying a military staff surgeon with 100 cases a year plus simulation is equivalent to a Boston trauma surgeon seeing 400 cases a year?
Seeing or doing?
Doing.
So, most of the learning in residency in the private sector is in the first 3 months after residency. Okay, so up until then, you're observing, you're watching, you're participating. They're holding the instruments. You're cutting in between the lines, or you're holding the instrument. And they only cut when you put it in the right spot. So, most of the decision making and growth is going to occur after you graduate. You have a license, and you're making the decision yourself. Up until then, it's a little different. So the inadequacies you feel, I think, in the military would be the same as a resident at Harvard, feeling the same thing. Now, some folks are just cocky and they think they can do everything, but they'll learn that in the first 3 months too, unfortunately, because it'll be a bad outcome. So I think you guys are doing great. I mean, I've seen 5 of you come through and right out of training, and I've seen people, 5 years out, you have the skills you need to specialize in pretty much whatever your interests are.
I think it's hard. I think to show that truly. So I would say just do what you have available, overdo for now, and that'll at least give you some level of confidence. But from the question earlier, that gave me an idea. I think you could just blow up a pig with some tannerite and have your resident save its life there. Okay, that wasn't appropriate or funny. But
Well, I think the challenge is resources and numbers, right? So it's, where are those cases? So if they're, as a Boston trauma surgeon, how many Boston trauma surgeons get 400, 500, 600 cases a year? Well, that's a very small number of the surgeons in the United States. So if we take that requirement and we try to expand that to every military surgeon, and that's just talking real numbers. So the reality, I think, is where simulation has its power, powerful, realistic simulation, is we can recreate that environment reproducibly. We define what the challenges and the skill sets are, and we can expose surgeons to do that, as well as all the other attributes that we need those surgeons to have. They have to have the ability to adapt. They have to be able to communicate. This are probably just as important, if not more important, than the ability to cut and sew well. Right? You have to be able to leverage your team. If you can't leverage your team, you can be the best technical surgeon out there, but if you can't do it all together and resuscitate concurrently and communicate your needs concurrently, the patient's outcome may or may not be better. I would argue probably worse. So I think in the end we can focus on the technical skills are important, but I think the idea is that in the power service is how we bring individuals and their skills together, and put it together as a team.
Now, if you want a curriculum when you're done, and you want someone to do the work for you and map out a pathway for hernia or biliary or foregut or colorectal or robotic or endoscopic, you're at the right place, because Stages is creating the master's program, which is looking at creating a curriculum for competency, proficiency, and mastery. So if you want someone to help guide you through your self-training of professional, deliberate, lifelong learning, we got it, and in about a year, we're going to have a really cool learning management system that we're putting in place to make it so you can get through all those things. So if those are the tracks that you're interested in, presumably you are because you're here, we got it for you.
Thank you. Awesome. Well, if there are any other questions, we'll conclude the panel discussion. We'll roll into the awards ceremony. I really want to thank the panelists for coming and joining us. Certainly, sitting Stages president is quite an honor. So.
Sorry, for the opening ceremony, a few quick things on we actually had we're actually very fortunate to have the opportunity to have the Madigan Color Guard actually coming to be part of the opening ceremony for Sages. Just a reminder for respect to colors and the likes, as we don't always do it. We don't always do it indoor ceremonies. So there's no rendering of arms. So you don't salute indoors. Simply standing at attention, facing and following the colors so it starts in the back of the room. You face the colors in the back of the room, and you shift and you follow and face the colors until it gets to the front. They're posted. So it's simply standing at attention. So just for consistency, so everybody knows the appropriate courtesies for today, I just wanted to let you all know that. Thank you.
So we should simulate a practice of that first before we get. Okay, while we're tallying up the scores for the awards, we're going to skip to a presentation to Dr. Jones first. He's got to go to the rehearsal ceremony before the opening ceremony. We've got to get him out of here. So I had the pleasure of introducing one of my mentors earlier, and now I had the chance to do it for my second mentor ever.
Oh, it's your second.
Well, he also took what Dr. Hetz did for me and took it to another level. It's pretty safe to say that none of you all would be here without Dr. Jones, though. He saw this plan that we had, that Gordy and I and Henry and a couple of those people put together, and said, "This is wonderful. How can Sages help you?" And he hasn't stopped Sages helping. Sages hasn't stopped helping since. It's been 9 years now. Every time I've asked for a favor or asked for a request to expand the program, it took him about 3 seconds to say yes. So here we are now, the Tri-Service Tri-Service Symposium. It's happened every year now for the past 5 years. We are thrilled. And we couldn't thank Dr. Jones anymore. So we have a little token for you, Dr. Schlussel, if you don't mind bringing it up. So what we have on here is one of the classic shadow boxes.
Wow, this is very cool.
There are coins from each service, plus the plaque and then a flag for him in the shadow box.
I may not make the opening ceremony. This is very cool, guys. Eric, get over here, Rob. So just to say a couple things, as you notice, Sages has a coin, and the reason we have it is General Woodson presented a coin to my son when he was an Eagle Scout. That's kind of why my son's off in reserve now. But in any case, it introduced me to the concept of coins, and Rob and Henry, Army Navy, taught me about the coins and how they got adopted. And so in San Diego, we brought coins to Sages because of you guys, right? So you're having influence you don't even know, and that's been continued now ever since, and it's a big deal to get a Sages coin at a Sages meeting. So again, thank you guys, and you're having an influence all the time, and you don't even know it. All right,
Dr. Jones, on that note, there you go. Thank you very much. Appreciate it. Awesome.
So that means if I find you in the bar, I always do.
Fair enough.
All right, thanks, guys.
So awards, so we'll start with basic science, moderators.
What's that?
Do you mind putting the awards PowerPoint up, please?
All right, so we will start with the Stephen Hetz Award, named after our guest speaker. So this is second place for the basic science session. And this award goes to Samuel Hopp for his paper on inhibition of TLR4 and hemorrhagic shock. So if he's here, come on up.
Picture.
Thank you very much. Thank you. Thank you, sir.
Congratulations.
Do we have the first place award? There we go. The first place award is the Paul Myers Award for the 2018 Basic Science presentation. And this goes to Dr. Rowan Sheldon for his paper on interventions for tension pneumothorax.
Tom, over here. Moderators. You're all we need.
Okay, I'm the lone remaining moderator from the trauma critical care session, which I guess is fitting because I'm one of the few trauma surgeons here. All right, so our second place award, the Peter Rhee Award, goes to Dr. Walker with his paper, Outcomes Following Administration of Tranexamic Acid in Military Traumatic Brain Injury. And our first place award in honor of Colonel Burris, it goes to Dr. Kucera and his paper, Improving Fasciotomy Performance, a Focused Needs Assessment for Military Surgeon Simulation Training.
Okay, to echo everyone else, we're really happy and grateful for y'all's submissions and presentations today. Everyone did quite excellent. The second place award, the Robert E. Lee Award, is going to Bigger is Not Better, 20-year institutional experience of atypical ductal hyperplasia, comparing the 11 and 8 gauge by Dr. Weiss. Okay. And our first place award, the Adam M. Robinson Award, goes to Bethany Hendrick for impact of number of lymph nodes and lung cancer resection on survival, 10-year experience.
Okay, and I think last but not least, this meeting also serves as the selection meeting for the resident COT paper competition for the Army State. And in that competition, we pick a top basic science and a top clinical paper. And those papers go on to be presented in the regional competition, which is at the American College of Surgeons meeting in October. And then one winner from the region goes on to represent all of the military at the national competition. And by the way, the military representative has now won the national competition in 2 of the last 6 years, I think, which is pretty impressive. So we're going to have a basic science and a clinical winner. I'll have them both come up here after we read your names. Our basic science winner is Dr. Rowan Sheldon, again, for his paper on interventions for tension pneumothorax. So come on up, Rowan. And our clinical representative will be Dr. Patrick Walker for his paper on tranexamic acid and TBI. Come on up, Patrick. And the COT certificate and plaques will be mailed to you guys because they don't have them made up yet. But congratulations.
All right, so that's the 5th Annual Military Surgical Symposium. I certainly have a few announcements here. One, I want to really thank Andrew Schlessel for doing some last minute. He was the one who was responsible for making the plaque, the shadow box for Dr. Jones, as well as those plaques. We had to do it last minute because our support from USIS, of no fault of their own, fell through late. And so really appreciate that. That really helped out. I really want to thank the program committee, also all the effort that went on over the last year with organizing and designing this symposium, all the abstracts and the presenters coming out here and presenting some really good quality research. Really enjoyed also the conversation and everyone's participation. I know it's been a long day, it usually is. Long day, full day. It's not over yet though. So there are a couple things, again, the Learning Center, so there's a sign-up sheet. Hopefully that's there. Hopefully people will be able to see that. Again, that's we've mentioned it several times. That's Thursday and Friday. Next is the opening ceremony. I believe that's at 5:30 in the Expo Center, is what my understanding is. 5:30 Expo Center. Correct me if that's wrong. So we'll meet there. And we do have also another item that SAGES has supported without question was we requested to have a reception. Nothing too fancy. It's on Thursday from 5 to 7, and it's really a meet and greet, chance for us to chit chat with senior leaders, surgeons, trainees, as well as civilians are invited as well. So that should be on the app. So if you're looking for the location and the time, it should be on the app. So with that, I really again want to thank everyone and enjoy the rest of the conference. And I'll see you in like a half an hour at the opening ceremony. Thank you.